introduce the next speaker. We'll have on the stage Dr. Abdulrahman Alqahtani. He's a consultant, interventional and structural at King Fahd Medical City. He will be talking to us about beyond TEER, what's the next and what's beyond.
Good morning, everyone. So hopefully, I'm not going to take 30 minutes. Hopefully, we'll make this shorter for you. So since this morning, we've heard multiple talks about structural intervention at different valves. We've heard over the last day and today a couple of advances and changes in TEER. I'm just going to go over the evidence slightly and then just touch on what's recent over the last 2 years. So we know that valve disease is very common, and it does become more prevalent as you age. Currently, about 10% of all individuals would have clinically relevant MR once they reach the age of 75. We know over both of the valves that mitral valve disease is very common and more prevalent compared to other valve disease. So we have to take a closer look into those patients, especially once they reach their 60s and 70s, and we'll find more relevant mitral valve disease. So in the early 60s, there was the first introduction of intervention, was surgical intervention for the mitral valve disease. At that time, it was the beginning of mitral valve repair, but there was no standardized approach yet at that time. In 1965, there was the introduction of the mitral valve replacement, and the first standardized tool came in 1980, which is the Carpentier technique. So what is the Carpentier technique? It's also known as the French correction. So it was the first standardized procedure in the toolbox for surgical techniques to treat the mitral valve. Basically, it involved fixing the posterior leaflet by making it basically shorter through resection. And that's in the case when you have a prolapsing or excessive tissue. It did provide an optimal long-term for isolated prolapse of the posterior leaflet. But the problem that if you have anterior leaflet or bileaflet, then you're doomed at that time. That's not something that would be working for. So moving forward until 10 years later, the Ottavio Alveri introduced his famous stitch. So basically known as the Alveri stitch, was basically approximation of the A2 and B2 as known as edge-to-edge surgical repair, basically. You're familiar with the different types of mitral regurgitation based on Carpentier classification. Commonly what we deal with is either degenerative or basically non-degenerative, but it comes to the fact that either the leaflet are normal, but there's excessive movement around them, or the LV is dilated, or there is abnormality within the leaflet. Commonly, what we deal with is Carpentier type 1 when we're talking about TEER, basically. So, what is the stance with regard to repair versus replacement for degenerative or primary mitral valve regurgitation? So, most of the studies show that surgical repair is the best approach. But unfortunately, it's not very standardized because it's dependent on also the surgeons and their skills and how much they do. There are operators who's mainly doing surgical mitral repair, and those who opt for surgical replacement. So mitral repair by far considered to be the best because of reduced perioperative mortality and improved long-term survival. And compared to replacement, it has shown optimal early and mid and long-term result with lower perioperative mortality. So why no surgery for surgical MR? The problem for secondary MR, the problem for those patients is dilated LV. And if you try to fix that with the valve, the LV might continue to dilate and will not have a proper remodeling, so you might not end up with the same result. So Alvira tried to resolve this by introducing a stitch and also considering an annuloplasty as well, annular ring, and therefore limiting the expansion of the LV and trying to resolve the problem that you're dealing with at the same time. So they showed that the 5 years freedom from operation was 92 if they had the Alvira stitch along with the annuloplasty ring versus 70% if they just had the annuloplasty ring. From that concept, we moved to basically build on it and bring the transcatheter edge-to-edge mitral repair. There was basically an improvement and milestones over the last 20 years till where we are right now. Started basically with the first publication and then the FDA approval. And then we started first for primary and then secondary mitral valve disease. And then we had also the result of the Pascal. Would that have changed the rate of surgical intervention? No. So the fact that despite the improvement and the abundance of the use of the transcatheter edge-to-edge repair in the mitral valve, the surgical repair remained the same. So we were not encroaching on the surgical patient. Instead, we were doing more sicker patients who were not basically offered the surgical intervention to start with. So for mitral tricuspid mitral edge-to-edge repair, that's a publication of FRS basically showed that mitral clip compared to it was effective in reducing MR than surgery, and it's associated with superior safety with similar improvement in clinical outcomes. If you look specifically, that the freedom from mitral valve surgery reoperation definitely better with surgery compared to mitral clip, but that's basically true in the first 6 months, and then after that it remained the same. And the reason for that, because if you have a problem with the mitral clip, you're going to see it quite often fast. And if it was successful, then you're not going to face any problem down the road. And the guidelines still consider for the guidelines consider still that says 2A for a patient who has basically degenerative mitral valve disease to consider for TEER. So how about for secondary? So 2 trials, main trials, landmark trial, but with different outcomes, the co-opt trials and the mitral France trial. So the co-opt trial showed that mitral clip versus medical therapy, that the hospitalization for heart failure and all-cause mortality within 24 months were reduced. Unlike mitral France did not show the same result, and the reason for that is they chose different pathologies. So a patient in co-op trial, they were mostly having severe MR, but the LV remodeling was not as bad. While in mitral France, they had less severe MR, but the LV was very dilated. And that's why they got different results and patients who actually benefit from TEER. So there are 3 cardinal co-opt-like profile that you have to consider if you want to embark on fixing mitral valve regurgitation using the transcatheter approach. So first, you need to make sure that there is no severe LV impairment. So the ejection fraction needs to be more than 20, and the LV in systolic dimension less than 70. So that's very important, because if the LV dimension was very large, then it will become very difficult to control that. That doesn't mean that those patients will not have benefit, but that's a different category. So those who drives the best benefit is those who does not have a very dilated LV. Second is the absence of right ventricular impairment with severe pulmonary hypertension. So you need to make sure that the RV is functioning well, that the RV systolic pressure or the systolic pulmonary artery pressure is less than 70, and then the patient does not have any hemodynamic instability. So those 3 important things, once they're present, then you're likely to have benefit in those patients who present with severe mitral regurgitation, and that's what's considered to be the co-opt-like trial. When you look at the outcome in co-opt-like versus no co-opt-like, you can see definitely there is significant difference between the 2 groups. So we should strive to try to get those patients who are co-opt-like in terms of their profile. And the guidelines still consider that the intervention for secondary MR is 2A, class 2A. So in general, the 2022 guidelines for heart failure treatment still consider the transcatheter edge-to-edge mitral valve repair as 2A, especially if those are suitable, which is the ejection fraction above 20, and LV in systolic dimension less than 70, and there is no severe pulmonary hypertension. So in summary, in terms of how you approach your patient with severe MR, so if it's primary MR, you would definitely have the hard discussion. If a patient inoperable and high surgical risk, then you could consider TEER. If they are not and you could offer them surgery, then surgery is the best option. And if the futility is high risk, then palliative. And for secondary MR, if they are co-opt-like, then the best approach also to consider TEER. And if they are not co-opt-like profile, then you still can consider give them an option of TEER, and we'll talk about that shortly. But other option is advanced heart failure management, including LVAD or heart transplant. And if they're not going to be a candidate, then a palliative approach will be considered in those patients. So we're not going to go in details about the devices. We know that currently there's two platforms, the Pascal and the mitral clip. And the differences between them is basically not a lot, but there's two major cardinal differences. In terms of evolution, we currently have the fourth generations of mitral clip, and we just mentioned recently what to do with patient who's not co-op trial. So beyond co-op trial, so the current guidelines recommend consideration of basically TEER in patients who do not fulfill co-op trials, but it might improve their quality of life and symptoms. So a patient who has advanced heart failure with reduced ejection fraction, those patients may benefit, and also those with atrial SMR. So this publication basically was 2 years back, basically considering the role of TEER in advanced heart failure, and if that would help patients to increase their eligibility for end-stage heart failure for transplantation. So those patients who received TEER, actually they have they become more eligible for transplantation because their pulmonary vascular resistance had dropped. So the moment you eliminated the mitral regurgitation, you have eventually drop in your pulmonary artery pressure and then pulmonary vascular resistance. So that's one of the things, but you have to send those patients to experience center where can they get really excellent intervention for that. And with atrial mitral regurgitation, so the right approach for those patients is not clearly known. Surgical or non-surgical, it's not really, we don't have much information on those. But the emerging evidence currently suggests that there is some kind of atrial reverse remodeling in patients who have an TEER if they have an atrial mitral regurgitation. So over the last 2 years, we have two major trials came out. The first one is ReShape trial, which was basically TEER versus goal-directed medical therapy. And basically, they took 500 patients and randomized them to optimal medical therapy versus TEER. And they looked into primary outcome was the heart failure, hospitalization, cardiovascular death within 24 months. So those who received TEER did very well compared to those with medical therapy. And also the hospitalization for heart failure within 2 years was significantly lower. And in terms of their quality of life, there was much improvement with TEER in those patients. So basically, TEER versus goal-directed medical therapy, it does better. Again, you try to choose the right profile of patient, and if they're not candidate, then you could still consider it, but with some cautions. The second one was the Matterhorn trial, which was basically TEER versus mitral valve surgery, and that basically a small number of patients in a few centers in Germany, about 210 patients randomized in one-to-one fashion to either TEER or surgery. And the primary endpoint was composite of death, hospitalization, or mitral valve intervention, or need for assist device implantation or stroke at 1 year. So what it shows that the TEER was non-inferior to surgery in this situation, and when it comes to safety, which is a composite of death, major bleeding, all intervention, M-TEER did outperform surgery. So those are the two major advances over the last 2 years in terms of landmark trial. This was the first one that's showing that head-to-head randomization in this setting. Again, the population in those patients were high risk, high surgical risk patient, but they were not inoperable patient. So, as Dr. Sundus mentioned, that we're trying to aim for precision in those patients, trying to eliminate MR as much as possible. We might have to tolerate a higher gradient at certain times as long as we believe that hemodynamics is better overall. So we try to give the patient the benefit of doubt in those interventions. So we strive for perfection in certain ways. So, we are introducing currently the Alfier stitch-like, which is the clip. So how about the ring in order to give the same result? So there are annular target annuloplasty intervention. They are not very well adopted, but it is there. It's available, either direct or indirect. And maybe in the future we will see an adoption of those annuloplasty approach in order to basically limit the dilatation of the LV and prevent further deterioration in those cases. Today we have two device systems, and we're striving to get less than 1+ of mitral regurgitation. However, currently we have the transcatheter mitral valve replacement. The new systems are coming out. The trials are enrolling currently, and hopefully we'll see adoption of this in the future, and this might be less invasive and more predictable outcome in those situations. So I think the future is heading that way. What is that for in terms of surgeon? Does that really affect their work? The reality is not. This is basically a study from the STS registry, basically looking at the mitral valve repair before the initiation of M-TEER and after the initiation of M-TEER. And what it shows basically that there is no change in the annualized mitral valve repair volume. What happened is basically they are actually doing less risk patient, and they have improved their 30 days mortality and 5 days mortality because they no longer have to deal with the high risk patient that we could offer them the option of M-TEER. So in summary, that transcatheter M-TEER is safe and effective in treating patients with both primary and secondary. The guidelines still consider it 2A. And technical improvement and increasing procedural experience have consolidated M-TEER as an effective option in selected patients with a wide range of anatomy. Thank you.
Thank you, Dr. Abdulrahman. Thank you, Dr. Abdulrahman. I'm going to have, since we have a 5 to 10 minutes talk, I would like to start with asking our surgeon. معلش يا دكتور فيصل يعني. He's our surgeon. We have to give him the praise. So there's a couple of points I want to stress on. The first one, the argument or the discussion that we have with our heart failure team, who should go first, the mitral TEER or the advanced therapy or LVAD? That's the first question. And the second question, with Metahorn coming on, what are your thoughts? I mean, we saw that there's no difference in the number, but when are you going to say, you know what, to the interventionist, take it, and when, no, give it to me? So 2 questions for you.
I'll start with the second question.
Yes.
I think the technology and I think imaging for mitral valve procedure is still evolving, as we can see. But adding and adopting the annuloplasty, I think, will add more to the strength of percutaneous mitral valve repair options. And when that happens, I think it will probably change, because from the surgical world, we don't just do the leaflet. We do the leaflet and the annulus all the time. And it has been proven that fixing the annulus actually affects the long-term outcome in terms of recurrence of mitral regurgitation. And I'm sure when the mitral valve prosthesis comes out, this also will shift the volume more toward percutaneous because of the replacement. All these patients who will go for replacement.
And what about like, would you go for an LVAD first in case of like, advanced heart failure, impaired LV, or you would still, do the TEER? I'm just gonna do the LVAD if you need to. Any thoughts about that?
I'm not a heart failure surgeon, but I would go with the less invasive one first.
Yeah,
Yeah, I think
according
so.
to you, I agree
Yeah.
with you. Dr. Faisal, same question in the reverse. So what do you think? You're gonna go always for an M-TEER, do it percutaneously, then talk to the heart failure people? The first question. Second question, are you gonna talk to Makhdoom, you know what, no, take this case, I don't wanna do it?
I'm going to answer the second question first. I lost the debate recently for the LVAD over mitral clip because if you talk to our heart transplant colleagues, the data for the bridge LVAD is definitely stronger. We only have one trial for the mitral clip in this cohort, and the outcome was a bit softer, delaying the inevitable, which is a transplant. I do believe that the volume of the mitral clip will be steady, not increasing, because if you also talk to our heart failure colleague and our AP colleague, they say advances in AFib prevention and ablation and maintaining patient in sinus rhythm will reduce the atrial fibrillation and hence some of the mitral regurg we are seeing. And in fact, some of our heart failure colleagues are debating that the mitral clip trial should be repeated with the current advanced heart failure therapy to see if there is really heart outcome. I think in our heart team, we always value a referral of a mitral clip that comes from a heart failure colleague, because that for me is an indication that this patient has been exhausted in terms of the heart failure therapy.
طيب, Dr. Ahmed, so yes.
So appreciated.
If you allow me, regarding the last point, regarding the heart failure and the LVAD and also the mitral clip, I will look at it by a different way actually. What's against sending your patient for mitral clip, try to buy time, then you can send him for the LVAD. Because we know in the beginning, we thought that the mitral clip by itself is preventing the patient to going for LVAD. But actually, if you end up your procedure with acceptable gradient, still your patient can go for the LVAD. Number two, also, if you think about our population is not exactly the same like the Western population. Some of them, they are living in a very remote area in the southern region, the north and the east. So who will take care of the device there? So really, there is a lot of limitation. So if you think about it, usually I will not make something fixed for all the patient, but really I will try to push to send this patient for mitral clip before considering the advanced therapy, because the advanced therapy actually still there is a risk of stroke. There is a lot of logistic which need to be addressed.
So Bandar, I think we have a debate going on. So Faisal, do you want to respond to that?
No, I support that, except if we want really to show that a device works, we should give it to the people that shows the best outcome. It's hard for you to see somebody saying, you did a mitral clip and the patient has 6 admission post-mitral clip. And that is why you have to pick and choose the best candidate in order to show the best outcome.
Yeah, totally agree.
Who's there that you pointed out who did have 6?
I'm kind of in between both. I think in our practice, we discuss them in the heart failure meeting with the surgeon and us interventionalists and the imaging colleagues. And I think depends on the patient. You have a patient that's a great candidate for VAD, great candidate for transplant, EF of 10-15%, you proceed with that therapy. But if you have a patient, maybe social issues are not so great, maybe the ability to follow up after a VAD or transplant is not so great, I think those are the patients, yes, they're not ideal candidates for CLIP, but we give them because the final therapy is a little bit riskier. So I think it's not an either or, but I think there is a role in a select group of patients.
If I don't mind, I totally agree with you, Doctor. And for the LVAD programs, I just be the devil advocate. The LVAD program, at least the LVAD program we have in our region, they're very dedicated. I'm sure they go through the patients very thoroughly. They follow up their patient very actively, and for those patients who lives remotely, don't have access to medical care, they will be excluded probably.
But what about the lifespan for these LVAD? For how long you will keep it? you think we can
So
bridge the
Ahmed
patient?
maybe can enlighten us about
up
that.
to-
What are your thoughts, Ahmed?
So going back, actually, the question is big. So the algorithm starts with stable, unstable, and what we're achieving in the patient first. If the patient stable enough, not stable enough. So the data we have from mitral bridge registry on 100 patients showed that you can bridge the patient to a different therapy, either an LVAD or transplant, or even improving the outcome afterwards. Some people actually came out of the transplant list. So it depends on the situation. As I said, we come like, you go to take the case to a heart valve team, and then you discuss. First of all, algorithm is stable and unstable, then what you want to achieve. Is it a bridging or a therapy or helping the GDMT?
Okay, I think with that we conclude our second session of the day. I thank all the panelists and the attendee and the speaker, Dr. Abdulrahman. And I think, I was the first talker. Thank you, everyone, and hope you have enjoyed the session. Thank you.
Okay.